Welcome to A Basic Introduction to Mechanical Ventilation. This is Chapter 1.5, Shunt. Now, in the previous section, we talked about VQ match and VQ mismatch. Shunt is one of the extremes of VQ mismatch. When we get an extremely low VQ ratio, this is known as a shunt. So remember, V is for ventilation and Q is for perfusion. Shunting can occur anytime there is low or no ventilation and adequate blood flow across the alveoli. At the alveoli, this is what an example of shunting would look like at its extreme. As you can see, the alveoli is very small. It's kind of filled in. There's not a lot of gas in the alveoli. And meanwhile, there's a blood vessel right below it, running right past it with flow, but no ability to pick up anything or exchange gas within that alveoli. A clinical clue to the presence of a shunt is extreme hypoxemia, and hypoxemia that is refractory to any form of oxygen therapy. So if you give them some oxygen and their oxygen saturations don't really go up, and you increase the amount of oxygen you're giving them, and there still isn't that much of a response, then you can be suspicious that a shunt is probably at play. If we look at a two-lung model, we can see how this actually occurs. Now, on the right-hand side of this two alveoli or two-lung model is a lung that is completely filled in with fluid and has no ability to exchange oxygen because it's completely filled in. Blood flow across the alveoli is normal on both the right and the left side, and when the blood comes to the middle after it's passed through the alveoli, it mixes, and then the total amount of oxygen saturation is the combination of those two oxygen saturations. So on the left-hand side, the alveoli has oxygen that is saturated at 75% as it enters the alveoli. This is normal. All of us have an oxygen saturation of about 75% when it's being returned to the lungs to pick up more oxygen. This saturation gives us a buffer in the event that we need to extract more oxygen when we're under extreme circumstances or stress. So regardless, on both sides coming into the alveoli, the oxygen saturations are 75%. On the right-hand side, which is normal, the oxygen gets picked up by the blood, and the oxygen saturations go up to 100% after they leave the alveoli. But on the left-hand side, the alveoli doesn't exchange any oxygen, and so the blood oxygen saturation remains the same at 75%. So it comes out on the other end at 75%. Now the 75% from the left-hand side and the 100% on the right-hand side mix, and this is something we call admixture, which is basically just a fancy way of saying mix. And we mix those two together, and then based on the relative perfusion and blood flow of the left versus the right, you can actually calculate the expected oxygen saturations. So in this circumstance, if 50% of blood flow goes through the left side and 50% goes through the right side, then when you mix 75 and 100% oxygen saturations, you come out with an average of 87.5%. You can also see that giving more oxygen in this circumstance isn't going to change anything. By increasing the FiO2 that you're giving the patient doesn't change the fact that that alveoli is completely filled in and there's absolutely no gas exchange occurring. And so when you give the oxygen, nothing happens. Sats are 75% going into the left side and come out on the left-hand side at 75%, regardless of whether you give them room air or 100% oxygen. So this is why shunting causes refractory hypoxemia. There are several things that can cause shunting or a shunting type physiology. And this is basically anything that can cause blood to effectively bypass the alveoli. So you can have shunting in patients who have a cardiac defect, and so blood is actually bypassing the lungs completely and going from the right side to the left side, and an intercardiac shunt. There are some interpulmonary conditions that can cause shunt, such as AVMs. And then at the alveoli level, you can think of anything that basically causes the alveoli to be collapsed or to be filled with something. Three things I usually list on my differential for things that fill an alveoli are blood, pus, and water. So blood, so pulmonary hemorrhage, pus, pneumonia, and water, pulmonary edema. So the key things to remember from this section are that shunt is an extreme form of VQ mismatch. It occurs when there's no ventilation but still retained perfusion, such that oxygen can't be picked up from the alveoli and transported into the blood. There are basically three things that you should think about when you see somebody who has refractory hypoxemia, and that is whether or not they have an intracardiac shunt, an interpulmonary shunt, or they have something filling their alveoli. And these things include blood, pus, and water.